Hello, I am your host, Dr. Jack Braha, and welcome to the Medcast Plus show. On the show, we will feature local community physicians who are experts in their respective field and who will share their experiences and wisdom with us. We cover a broad range of health topics on the show, and today we will discuss colon cancer. March is Colon Cancer Awareness Month and an important reminder for us to undergo colon cancer screening. Colon cancer is the third most common cancer, and unfortunately, over 50,000 people died of colon cancer in 2017. According to data from the National Cancer Institute, the risk of developing colon cancer is about 4 to 5%, and there are over 135,000 new cases diagnosed each year in America. With increased screening, the rates of colon cancer are declining in people over the age of 50, but new data suggests a rise in colon cancer in younger patients. 1 in 7 cases are now diagnosed in patients under the age of 50. There are ways of preventing colon cancer. First, it is important to have a conversation with your primary care physician or gastroenterologist to determine your risk factors. Average risk individuals should be screened at age 50, or if African American, the American College of Gastroenterology suggests beginning at age 45. One of the most common ways of screening, and the only way where you can find and remove precancerous cells, is with a colonoscopy. Precancerous cells accumulate to form polyps. These are small bumps or growths in the colon that can be removed during a colonoscopy. Preventing colon cancer with colonoscopy is important. Colonoscopy is painless when performed with intravenous sedation and takes about 15 minutes to complete. Here in Brooklyn at our colonoscopy center, we find precancerous polyps in about 30% of the patients we see. There are certain factors that would require someone to begin screening before the age of 45 or 50. These factors include a family history of colon cancer or advanced polyps, inflammatory bowel disease such as Crohn's or colitis, or other inherited genetic disorders. Today we have the honor of welcoming Dr. Hans Burkholder. He is a colon and rectal surgeon practicing here in Brooklyn. He is here today to discuss colon cancer and other related diseases of the colon and rectum. He treats patients with colon cancer in his practice, and he is a board-certified physician. He is board-certified in colon and rectal surgery and has advanced training. Prior to coming to Brooklyn, he completed medical school at NYU and moved on to practicing colorectal surgery and trauma surgery in Anchorage, Alaska. There he was the director of trauma surgery at Anchorage Regional Hospital. He is currently in faculty practice at Brookdale University Hospital and also operates at Methodist Hospital in Park Slope. Welcome, Dr. Burkholder. An honor to have you here on the show.
Thank you for bringing me.
Hans, Dr. Burkholder, we have worked together somewhat. We've had mutual patients, and I have to say thank you for providing world-class care here in Brooklyn for my patients. They love you, I love you, and I'm happy to have you here today to discuss colon cancer and some other diseases of the colon and rectum in which you specialize in. So as a gastroenterologist, I meet a patient, I do a colonoscopy for screening, I find a cancer, and we get a biopsy, we do a CAT scan, we do some blood work, and we determine that a patient needs surgery. And I tell them, here's a list of the doctors in Brooklyn. They end up in your office. What's the next step?
The next step is often just talking with the patient and helping them to work through some of their anxieties around the new diagnosis, because if the patient isn't able to cope with the emotions they have surrounding the diagnosis, they may delay treatment or not get things done as expeditiously as they should. So the first step is making sure the patient understands what the diagnosis is and what the treatment options are.
So the first meeting you have with them, you sit down sort of as we are today with a desk. There's no procedures that day.
Exactly. The first step is to gather all the information, make sure that the cancer has had the appropriate staging workup so that we know exactly what stage the cancer is, so that we can develop the best treatment plan for that patient. And that often involves, more doctors than just me. It often involves an oncologist, a gastroenterologist like yourself. So there's usually a whole team of doctors that are making decisions together about the treatment plan and workup for these patients.
And that's true today for nearly all cancers. It's a team approach. There is the primary care doctor who has to help us all make sure the patient is safe to undergo surgery. In colon cancer, we find them as gastroenterologists most of the time. We refer them to you as well as to a oncologist, which is a cancer doctor. These are the folks who give chemotherapies, or what we call radiation oncologists who give radiation therapies. And so we put the team together, they meet with you in the office, and let's take a hypothetical patient who is early stage. Can they go directly to surgery and to cure?
So once the medical doctor has cleared them for surgery, a lot of times surgery is the next step for that patient. And I always enjoy treating those patients because their chance for cure with surgery is very, very high. And so it's good news for those people when we do all the CT scans, the blood work, and we find that our chance for a cure with surgery is going to be in the high 90s. So that's always very good news.
Right, and you mentioned that statistic, which is a very, very important statistic, and it shows how well we have done with this disease, is that from the National Cancer Institute, the 5-year survival for a patient diagnosed with early colon cancer, meaning they met us somewhere early in their disease, I did a colonoscopy, we found an early cancer, their survival at 5 years is 90% or better in most cases. That's incredible.
It's amazing with the advances in surgical and medical care, how a disease that used to have a much higher mortality we're able to treat once it's found, but also with appropriate screening, prevent from happening. And colon cancer is not happening as often as it used to, thank goodness.
Right, the preventative measures for colon cancer, the most important is to simply get checked, to undergo screening for colon cancer, which in my practice as a gastroenterologist, colonoscopy is the most common way that we're screening for this. That's a test where I take a little camera and we look through the colon while the patient's sleeping. It takes about 15 minutes. And it's done at the age of 50, sometimes earlier. For certain patient populations, we start at a younger age. I find polyps and remove them, and because we as gastroenterologists are finding these polyps early when they are a pre-cancerous condition, we're actually taking away some business from the colorectal surgeons because less and less patients over the age of 50 are getting colon cancer.
And I would love if you guys would make me obsolete.
We would love to make you obsolete too, because if you did not have business, that means we were successful.
Exactly.
That means we found the polyps, and even sometimes polyps that have a little small cancer in them, I can cure them during a colonoscopy by removing the polyp, and then they just need to be watched without surgery, which is fascinating. But the problem I see is we have a higher or a rising rate of cancer in young patients. And that brings me to my next question. When I meet a patient who has rectal bleeding, meaning they go to the bathroom and they poop or move their bowels, however you want to say it, and they see some blood. Now, in my practice, I see that in all ages, young patients, middle-aged, older folks. What's your approach to patients who have blood per rectum, blood when they move their bowels?
So my approach with them is to do a complete history and physical exam and see if I can see on physical exam what may be causing the bleeding. And most patients who come to my office with bleeding do not have colon or rectal cancer, but that's always in the back of our mind as something to be concerned about. So we'll look for things like hemorrhoids, anal fistulas, anal fissures. Those are all things that can cause bleeding and are not cancerous conditions, but those patients need to come in and be checked. And I have patients who come in telling me they have hemorrhoids that are bleeding and they've been ignoring them, and I look and they're not hemorrhoids, so it could be a cancer.
Right. And that is an important thing today with the rising rate of colon cancer in folks under the age of 50. We know 1 in 7 of these cancers are going to be in someone under 50, so they will have not yet undergone a colonoscopy for screening. So someone comes into my office with rectal bleeding. I've had cases of young men, young women who have been told by other folks, whether they're medical professionals or even looking on the internet, that it's hemorrhoids and not to worry, when in fact, we always do colonoscopy or sigmoidoscopy, some investigation. And I have found cancers in 30-year-olds and 20-year-olds. I have found polyps in young people. And we have to all be aware that bleeding is always abnormal no matter where we think it is coming from. And so if I go ahead and I do a colonoscopy on a patient and I find this tumor, a cancer, they end up in your operating room. How do you remove the tumor? What techniques are you using today?
So in most cases, we're able to use minimally invasive techniques, which can be laparoscopic or robotic, and remove a lot of these cancers with those minimally invasive techniques. And that's important for the patients because they have a lot less pain with surgery. The recovery process, they recover a lot more quickly and just overall get back to feeling themselves a lot faster than what people did decades ago with the more traditional surgical methods.
And we call the older method, or the more traditional method, which is still done for patients who need that, is a laparotomy, correct?
Correct.
And that is the scar or the line that we all know of from TV shows or
Right.
from seeing folks on the beach sometimes, which is a scar from the bottom of the chest down to the belly button. That's a laparotomy scar.
Right.
Now, I've sent you patients and other colon and rectal surgery patients, and they have seen other surgeons too, where they come into my office, they have had a colon cancer removed, and I can barely tell.
Yeah, in some patients, if the scars are placed in the right place, they're cosmetically very hard to see. And so some patients have a very good cosmetic result.
And not only for cosmetic reasons, but for recovery. They're able to get out of bed quicker, they're able to go home quicker. Is that true?
That's true. And in addition to the advances in minimally invasive surgery, there's new advanced enhanced recovery protocols that are speeding up the time that people can get out of the hospital, have bowel function, start eating. There's less nausea with these enhanced recovery protocols, and so patients are doing much better with some of these new.
And this enhanced recovery really means that as soon as you're done sewing up the last cut in the operating room, recovery begins almost as they're being wheeled out the door.
Right, and it really has taken the treatment focus off of just doing the surgery to how we treat patients both before the surgery in terms of what we give them to eat, how we do the bowel prep, but also after the surgery, how we manage their pain, how aggressive we are about getting them walking as quickly as possible. And a lot of these non-surgery adjuncts are really getting people better faster, and we've found they have a lot less discomfort, a lot less nausea, and the surgery is much easier for them to go through with these new protocols.
So after someone comes and meets you, they have an early colon cancer or whatever it might be that has to be removed from the colon, you're trying to get them back up, walking, eating. How soon?
Ideally the same day for getting up and walking.
The same day as surgery, you are getting people out of bed.
Yes, as soon as the anesthesia wears off, we want them out of bed, sitting in a chair, and once they're not feeling lightheaded or dizzy from the anesthesia, getting up and walking with assistance.
Fantastic.
And we're usually starting clear liquids the same day, and if they're tolerating clear liquids, the following day starting a regular diet.
So this is different from when we trained as medical students and even as residents years ago, that we used to slowly, the next day maybe, get someone to swing their legs out of the bed,
Right.
Wait for them to pass flatus or gas, wait for them to have a bowel movement before we would even think about giving them a glass of water even sometimes.
We've really found that by minimizing the amount of tubes we leave in people, we would put nasogastric tubes in, which were very uncomfortable for patients, taking the Foley catheter out of their bladder as soon as possible after surgery. The less tubes and things that people have going into their bodies, the better they do in general.
These are common sense things that we used to talk about, but have been studied now and have been proven to enhance the recovery. So folks now come out of the operating room, they're moving, they're eating quicker, and they're getting out of the hospital. How long does the average patient after a colon resection for cancer stay in the hospital?
For the average patient with very few medical problems, somewhere between 2 to 5 days is the average now for these enhanced recovery protocols. And generally, people are leaving the hospital when they're feeling like they're ready. It's not like we're rushing them out. But usually by the second, third, fourth day, people are feeling well enough that they just don't want to be in the
Right.
hospital anymore and they want to leave.
Most patients don't want to stay in the hospital. It's
Right.
not a hotel, it's not a resort. Hospitals are tough places, hard to sleep. We catch infections in the hospital, and So I agree in my practice as well. Obviously, I don't do colon surgeries, but after doing certain types of our procedures or for other reasons, I really encourage patients, ambulate, get out of bed quickly, move your extremities. A body in motion stays in motion, and it is good for their health. And we're seeing it now. You're able to get patients out of the hospital so quickly after a colon resection. So this offers hope to our viewers and to our patients that, God forbid, they have a friend or a family member or themselves where they've been diagnosed with something like this. They're going to be able to go to a surgeon like you, have a minimally invasive surgery, minimal scar, minimal recovery time, and cure colon cancer.
Yeah, it's really amazing that we're able to do this. When you think back to what people used to have to go through, we've really made a lot of advances with modern medicine, and I think there's even more to come. But I think it's really important that the viewers understand most people who have colon cancer, this is a preventable disease, and by getting screened, they can avoid the surgery and not have to go through all of this.
That's the goal. The goal here in Brooklyn and nationwide is we want all patients who are candidates for screening, who can undergo the screening, to come and see us. There are options to get screened, and preventing this disease is our goal. We don't want them to end up in your hands, unfortunately. You're a crafty and talented surgeon, but I would prefer that we eliminate colon cancer. And we started out the conversation a little while ago about surgery, talking about rectal bleeding. And we know, thank goodness, not all rectal bleeding is cancer, and not all rectal bleeding is as simple as a hemorrhoid from pushing or straining. And in my practice and in the practice of gastroenterology, we are taught to investigate bleeding no matter the age, no matter the circumstance. And so sometimes I do colonoscopies and I find that there is nothing wrong inside the colon. The bleeding looks like it came from a big external hemorrhoid possibly, or a large internal hemorrhoid. Maybe the patient was very constipated, maybe they were pushing very hard, or they have a job where they're sitting all day long. And we have ways as gastroenterologists to help, particularly the internal hemorrhoids, by putting bands. We can put rubber bands on the hemorrhoid. We can burn the hemorrhoid using IRC, which is infrared heat. Some patients refer to this as a laser.
Right.
It's not in fact a laser, but it is a heat process. But sometimes I have to send them over to you for treatment of hemorrhoids. So talk to me. Say I'm the patient who comes in with rectal bleeding and I've got an external hemorrhoid that really has caused me pain and bleeding, and I want to have it removed or fixed. How do you approach the situation?
So I make sure that the patient understands the disease process, understands what their treatment options are, and there's some people that we can get better just with diet and lifestyle changes, and they don't even have to have a surgical procedure done. For people who have tried those things and they haven't worked, there are surgery procedures such as hemorrhoidectomy that we can do to get rid of the bleeding. You mentioned other options like rubber band ligation or infrared coagulation, which are almost painless procedures. And those are things we offer to patients to try to get the bleeding to stop. But I think it is really important, as you mentioned, that people who have bleeding, even if they attribute it to things like hemorrhoids, get it checked out, get a health professional to look and make sure that that's actually what's going on.
Right. And so other sources of bleeding we should talk about. Anal fissures. Sometimes they can bleed. And for the viewers at home, explain to us what an anal fissure is in some simple lay terms that our folks at home can understand.
So an anal fissure happens, usually people have a traumatic bowel movement where they were constipated and the opening tears a little bit. The anal muscle then becomes too tight as a reaction to that. And so every time they go to the bathroom, they have some pain and some bleeding. And it's really because the opening is too tight.
Right.
And so with treatments, usually medications is how we start. With medications or with surgical procedures, we can get those people better and get their pain and bleeding to stop.
Right, so one of the classic histories I take in the office is a patient who comes in and says, listen, I was constipated a week or two ago, I really was straining, the stool was very large or hard, and I had terrible pain after I saw a touch of blood. And now the patient says to me, every time I go, it is painful. It burns and then it throbs after. And that's almost 100% diagnostic for an anal fissure in my office. I would say 99% of the time when that is the story, on exam I am finding an anal fissure. And so we use what you said, topical therapies. I have read and I have seen you do certain procedures on my patients and other docs that we can use Botox, in fact.
Correct. That's one of the newer treatments for anal fissures, and basically the problem is the muscle is too tight. So by using Botox, it's the same Botox you use on your face, you can...
Different needle.
Exactly. You can paralyze the anal muscle and make that opening a little larger using Botox, and about 80% of patients will get their fissure to heal using Botox. And so it's a very good new technique to use for these anal fissures.
And the last resort, obviously, is we have some surgical procedures for patients with refractory or fissures that will not heal on their own.
Right, and that procedure is called a sphincterotomy, where we actually cut a little bit of the muscle that's making the opening too tight, and by cutting it, the opening becomes a little bigger, it lets bowel movements come out easier, and allows the fissure to heal.
Right, and this is all in addition to talking about diet. I educate my patients on fiber, sitting in a warm bath here and there. What other natural ways or lifestyle ways can you suggest, to help our patients with this?
So for people who have fissures, the best way to get these to heal naturally is with a good healthy diet, which means lots of fiber, lots of fruits and vegetables, taking a fiber supplement if they're not getting enough through fruits and vegetables. And that's the main natural way to get these to heal.
Right. I suggest to my patients a bowl of fiber cereal in the morning and then try to incorporate a large salad later in the day, because many of the diseases that you and I deal with in the area of the rectum or the anus can be helped with an improved diet or improving their bowel function. I want to move on to another topic related to rectal bleeding, and that is the inflammatory bowel diseases. So another reason why we investigate folks who have recurrent episodes of bleeding, particularly if their blood counts are abnormal, if they're having changes in their bowel habits. For example, if someone comes to us with diarrhea and they have bleeding and some abdominal pain or weight loss, certainly we do colonoscopies or other types of procedures to diagnose not just cancer, not just hemorrhoids or fissures, but to look for Crohn's and colitis. Unfortunately, some of these diseases are going to require that I involve you in their care or a rectal surgeon or colon surgeon in their care. For folks who unfortunately end up in your hands and need to have surgery, what are some of the things that you're doing? Are there still minimally invasive techniques if someone needs to have their colon removed or have a piece of bowel removed due to Crohn's? How do you approach this as well?
So we tailor the treatment to the patient because every patient is different. But as often as possible, if people are a candidate for minimally invasive techniques, we're going to do those. And so for a lot of people who have Crohn's disease or ulcerative colitis, there are minimally invasive surgical techniques that we can do to treat their small bowel or colonic disease. I think it's really important for those people that they have a regular screening exam by their gastroenterologist because of the increased risk of colon cancer in those diseases. So it's very important that they also get checked.
You bring up an important topic there. We started off the segment today talking about colon cancer risk. And so one of the increased risk factors for colon cancer, inflammatory bowel disease, like, for example, folks with ulcerative colitis, we will do colonoscopies on them quite frequently. Unfortunately, there are some times where we may find polyps or what we call dysplasia, abnormal tissue changes inside the colon, and they require what we call a colectomy. And that's where a colon and rectal surgeon, such as you, Dr. Burkholder, will have to remove the colon. But I want you to touch a little bit on this because we had a patient on our previous segment who was worried about colostomy.
Right.
And tell us, not every patient ends up requiring a colostomy, or sometimes they have just a temporary. Educate our viewers today on why folks who need to have their colon removed may not always need to have what we call a bag or a colostomy.
Right. So that's one of the fears that many patients have when I first meet them, and it's one of the questions that they'll often ask at our first meeting is, am I going to need to have a bag? And for most people, the answer is that they're probably not going to need one. Most colon surgeries can be done without requiring patients to have a bag. I will say that for patients who do have one, it often winds up not being as bad as they feared it would be to have it, but we, in most cases, can avoid giving patients a bag, and I'm always happy when I finish a surgery and one isn't required. And even if people do require a bag, a lot of times it's temporary and can be eventually removed, and they can go back to having bowel movements the normal way again.
Right. It is rare today. There are certainly instances where it can occur where someone needs a bag or a colostomy. But for most patients, they end up waking up without one, or it's temporary and
Correct.
can be usually 3 or 6 months down the line reversed. Is that true?
Correct. It often depends on whether or not there's other treatments needed, such as chemotherapy, but usually within 3 months they can be reversed.
So we covered colon surgery and rectal surgery for both cancers, possibly for other diseases like Crohn's, colitis. And from what you're telling me, it sounds like these can be done minimally invasive. Patients are getting up, walking quicker, often avoiding colostomy or avoiding the bag. Even if they need one, oftentimes it's reversed quickly. And so it's very encouraging what we're seeing out of the colon and rectal surgery world. Obviously, as gastroenterologists, we'd love to treat all these diseases with medicines or diet or colonoscopies, but we need folks like you. Now, you're practicing here in Brooklyn. When someone comes to you with any of these colon and rectal diseases, and you operate out of some local hospitals here, do you see an increased risk of any one of these more than you saw elsewhere in your practice, whether when you were in Manhattan or when you were in Alaska?
So I think I've definitely seen a trend towards younger patients. I've had patients, like you mentioned, in their 20s who had colon cancer. There's also an increased risk in minorities to have colon and rectal cancer, and so I've certainly seen that trend in my practice here compared to my prior practice.
And this is a very important point, and I'm happy you brought that up, and we're going to end on this point. We are seeing these diseases in younger folks, and we are seeing that minorities have an increased risk. For example, the African American population has a higher risk of cancer. And I'm glad you brought that up as a unique issue here in Brooklyn, and I hope folks will come out and see their gastroenterologist, see their colon and rectal surgeon, and their primary care physician to help prevent diseases such as this. I want to thank you, and I'd like to thank Dr. Burkholder for joining us today. Thank you for your interest in our show and your desire to become more involved and educated about your health. I invite you to visit our website, www.medcastplus.com, and check out our tools and connect with us on social media. You can also call us at 718-510-2103. I am Dr. Jack Braha. Thank you for watching. Stay well and stay healthy, Brooklyn. Goodbye.